Welcome back to PT Meal Physical Therapy Podcast, your weekly serving of physical therapy information and inspiration from Filipino physical therapists. For this episode, we're going to talk about home health setting in the US and what it is. I started in home health when I moved in here in the US and I enjoyed it. So for um, this episode is for anyone who's going to be starting in home health and or thinking about moving into the home health setting. So, who better to learn about home health than someone who has their own home health practice and climbed the ladder for today's episode? We have Eleazar Tayag. Ellie, welcome to the show.
Hi, everyone.
Hi. So, I met you in the recently concluded CSM, right, in Colorado, and we had fun doing karaoke with
Yeah.
other Filipino physical therapists. But most importantly, you were there uh, for your board certification, right? For your
Yes.
second board certification as a clinical
Second board.
specialist in orthopedic uh, physical therapy, correct?
So
Right.
I'm board certified in uh, geriatric and orthopedic physical therapy.
Yeah, so double certification. That's amazing. So, personally, what does it mean for you to be a board certified clinical specialist?
Actually, uh, it's really funny. I've been practicing as a physical therapist almost, I would say, a decade and a half,
Mm-hmm.
and I never thought of clinical specializations until after end of 2016. This is when I took my doctorate in physical therapy from EIM Institute of Health Professions. That's where I gained momentum
Mm-hmm.
and pretty much got that inspiration to think about my myself and my progress as a physical therapist. So I started reviewing, not really reviewing, but preparing for it when I started my DPT. So I thought, being a specialist will make a huge difference when it comes to um, our practice as a setting, because there's it's not really common for physical therapists to pursue specialization when they are in home health. I don't know. This
Right.
is a common thing that I've seen over the years. So that inspired me pretty much, and eventually, I took the test and passed the GCS in
Mm-hmm.
2018 and the OCS in 2019. I
Mm-hmm.
feel like it is good for me professionally and overall excellent for my practice in the home health setting, and it will help me make sure that everything that we do in home health are evidence based, all that stuff.
Right, I totally agree. I worked in home health. Me and my friends work in home health in Maryland, and that's why we also decided to get the certified in geriatric physical therapy, because we thought that since we're already practicing with the geriatric population, what better way to give up our best than
Correct.
be certified. Mhm.
Yeah,
All
and
right.
on top of that, with the inspiration from the Academy of Filipino American Therapists, with the leadership of uh, Dr. Baloy,
Mm-hmm.
it inspired a lot of Filipino physical therapists to actually work into their doctorate, into their
Mm-hmm.
specialization, or whatever progress they want to do in their professional careers.
Right, right. Because we see every year that they post about their certification and how they meet and CSM, have fun. So and also like yeah, advancing our profession and ourselves. Very yeah, it's inspiring. So let's now go to before we go to the topic. So Could you give us a little background how you started in physical therapy and to going to now to your current practice?
Okay, so it's a long story. So pretty much, I am a true-blooded provinciano from Lingayen, Pangasinan. So I was born in Lingayen, Pangasinan in the Philippines. So both my parents were public school teachers, and pretty much being in the medical field is the how do you say, my father's American dream. So he
Mm-hmm.
was I would say frustrated U.S. Navy applicant in the 1960s.
Mm-hmm.
So I I don't know what happened to him, but in the 1960s, my uncle and my dad actually took a test to become U.S. Navy, and my uncle was able to get in, and my dad did not. So moving forward, my dad always wanted us to have the American dream. So he knew that being in the medical field will pretty much fulfill our American dream. That's why 3 out of 4 of us siblings, one is a dialysis registered nurse in Chino Hills, California, and my other brother that you met, Erds, who
Mm-hmm.
is working as a geriatric physical therapist in Seattle. So
Mm-hmm.
that's why we're all here. So you know, my backstory is like this. So it was not physical therapy, which was my first course. So after graduating from high school, um, I was a freshman at the University of the Philippines Manila for pre-dentistry. So I
Oh.
was on my way to becoming a dentist. That was my goal in life that time. But my father, who convinced us to become health professionals, actually became terminally ill. So I had to make a decision of moving back to the province and you know finishing the dentistry course or go another route. But you know, practically thinking that time, my brother, who was already in his third year as a physical therapy student in the province, already had so many books for physical therapy. So I said, okay, I might just well inherit all his therapy books. So then,
Practical.
yeah, and that's it. So the rest is history. I became a physical therapist. So after graduating, I taught physical therapy in 2 local universities. Then eventually got promoted as college dean of the University of Pangasinan at the age of 22. Then
Wow.
in 2005, moved to the United States to join my wife and my son.
Mm-hmm.
So that's my history in the Philippines. So I moved in California in September 2005, and I had to go through the usual professional journey of most foreign educated physical therapists. Started as a rehab aide. I was a rehab aide. Then after passing my licensure exam, I would say around March of 2006, I became a PT license applicant. I'm not sure if you ever had you never had to go through that, right? Because
No,
you came
I
from
because I came from Maryland, so I just submitted my hours or my years of practice in
oh,
Maryland.
that's wonderful. For us, we had to go through the PT license applicant for 9 months. So I worked in an workers' comp outpatient therapy place. Then eventually, after becoming a full-fledged PT here in California, we bought a house in Victorville, and where I started working in a skilled nursing facility. Then from one skilled nursing facility to having part-time skilled nurse, another skilled nursing facility. Then one of the physical therapists here in the high desert actually introduced me to home health. So he had a contract with the home health agency.
Mm-hmm.
Then after that, I think his son got sick, so they had to move to Texas. And there, I inherited his contract from that local home health agency. So that's where everything started. So
Mm.
I started my own home health contracting business. So from one agency, and I would say in 2007, to around almost 90 home health agencies all over Southern
Wow.
California, probably in 3 years' time. So
Mm-hmm.
I probably had, I would say, almost 80 therapists, PTs, OTs, speech, and
Mm-hmm.
assistants. In 2013, end of 2013, you know, one of an older Filipina lady is about to close her home health agency. So she owed me money. So when I was speaking to her, she told me, "Do you know anyone that's interested in buying a home health agency?"
Wow.
So it was like a once in a lifetime opportunity. So
Mm-hmm.
my wife and I and a partner actually you know thought about doing it. So
Mm-hmm.
it was a of faith for us. So we acquired Imperial Home Health January of 2014 with only probably around 7 patients left. So
Mm-hmm.
from 7 patients, uh, we turned it around. We're now several hundreds of patients for our
Wow.
home agency.
Mm.
In 2018, we acquired another home health agency based in Ontario. The name is Golden Seal Home Health. And just this year, we acquired a hospice agency based in Riverside, which is we are moving here in Victorville. So
Mm-hmm.
pretty much that's how my home health journey, you know, came to full circle from being a clinician to owning a home health agency and hospice
Mm-hmm.
agency.
Oh, wow. Wow, that's probably a combination of what do you got, timing and experience and a lot of things, right?
A lot of things. Yeah, we can talk that later. What entails to own a home health practice
Mm-hmm.
or business? It takes a lot of guts.
Mm-hmm. Right. But was that really your end goal when you were started that you wanted to really own your home health practice?
Actually, it was not.
Uh-huh.
Initially we were contracted with several home health agencies.
Mm-hmm.
From one home health agency, then eventually two, three, then 10, then became
Mm-hmm.
20.
Mm-hmm.
Then eventually you will come to a point where it gets to a saturation level and you'll say, okay, is this really what I want? So it came to that point that we're growing, but we're not really growing.
Mm-hmm.
We were still at the mercy of these home health agencies based on their practices. I was not really happy how they treated their patients overall.
Mm-hmm.
Uh, they are dictating the number of visits
Mm-hmm.
and all that. It's not medical necessity. So I said, you know what? I'm done with this.
Mm-hmm.
So I said, okay, when that opportunity came, I said, okay, I think it's time to move forward, and said we can do better than all of these people.
Right.
So
Right.
so my wife and I, so we were partners in all of these businesses. So we said, okay, it's time to move up and spread our wings a little bit more. So from home health, then eventually, when you learn home health from scratch,
Mm-hmm.
and you get better at it, eventually you look for another avenue, which became hospice. So we have a lot of plans in the future, but we're trying to do it one step at a time. We can't be too far ahead that we have to do some kind of calculated steps
Mm-hmm.
overall. So that
Mm-hmm.
we did, but it was never a plan to actually
Oh
own a
wow.
home health.
So probably it was being offered to you, the opportunity open, and you're just like, okay, I'm gonna grab it because I've been thinking about going to having my own practice, and I'm not gonna let this go.
Right. And initially when we were doing what's this home health contracting,
Mhm,
our initial goal was to eventually own our own outpatient practice.
mhm.
So
Oh,
actually, we said we dropped that idea. We thought, a home health practice is a lot better than an outpatient practice. But in the future, I'm sure one of these days, I'm still thinking of really having an outpatient
mm,
practice aside having home health and
right,
hospice.
right. Because a lot of home health patients, after being discharged from home health, are asking, where can I go after this?
Yeah,
So exactly, an outpatient facility would be the best next thing after home
correct,
health.
correct. And on top of that, we have the ability to do home health Medicare B at the patient. I mean,
Correct.
physical Medicare B
B.
at the patient's homes.
Mm-hmm.
But we haven't really gotten into that practice yet
Mm-hmm.
because all of these things happening currently with the pandemic. With
Right.
the PDGM, we thought of doing that
Mm-hmm.
program. That this happened, so it put
Mm-hmm.
everything
On hold.
on.
Right. Okay. So so again, I said in the early part of the show that we're going to talk about home health. So what is exactly is home health here in the U.S. for those who are not familiar?
Okay, so pretty much what I'm going to tell everyone is on a perspective of home health as a physical therapist and a perspective of home health as a clinical manager in charge of the clinical operations of an entire agency. But normally, I know you've done home health in Maryland. I'm not sure if you're doing it currently. Are you doing home health
No,
currently?
I'm in sniff right now, but I'm trying to look for some per diem positions for home health just to uh,
Oh, okay.
do it in the weekends or something.
Oh, okay, that's wonderful.
Mhm.
So, home health practice is one of the post-acute settings that a patient. I mean, home health is one of the post-acute settings that a patient can choose from after a short stay from an acute hospital.
Mhm.
So, the post-acute choices are acute rehab. If you're familiar, like
Mhm.
Ballard here in I think there's one in Pomona, and skilled nursing. Sorry.
It's okay.
Okay, so skilled nursing. Yeah, this is the joys of having a. And this
Right.
thing is it's recorded.
Yeah.
It's
Well,
live.
we can edit it later on.
Yeah, it's okay. It makes it more natural and
Uh-huh.
candid. So yeah, aside from the acute care, I mean acute rehab, then patients can look into skilled nursing facility, long-term care facility, outpatient, or home health. So
Mhm.
home health is one of the few choices. Unlike the skilled nursing facility, which require 3 full days of admission in the acute hospital, which is currently waived because of the pandemic. To be eligible in home health, it's a little bit less restrictive because there's really no set length of stay to be eligible. So any acute or post-acute or community facility can refer to home health so long as they are eligible for Medicare and Medicare Advantage patients. There are 5 important things so that they can qualify for home health. They have to be under the care of a medical doctor who regularly reviews the plan of care, and this doctor has to certify at least one of the services, like intermittent skilled nursing. For example, they need medication management, wound care, and so on and so forth. There's PT, there's speech, there's occupational therapy. Number three, they have to be under a home health agency, which is Medicare certified. So you have to be Medicare certified to be seen in home health. Number four, they have to be homebound. Homebound, is a totally different aspect. We cannot discuss it currently because it's a very complicated explanation. And number
Yeah.
five, face-to-face encounter. They have to have an encounter with a medical doctor, and with the new waiver for the pandemic, a nurse practitioner or a physician assistant can actually do the face-to-face encounter at this time. So
Mm-hmm.
including telehealth
Mm-hmm.
encounters. So, for practitioners in home health, especially physical therapists, for example, they have two options. Are they going to restore the patient's functional status, or are they going to maintain? So there's a restoration piece, there's a maintenance piece. A lot of
Mm-hmm.
home health at this point in time, prior to the GMO versus Sibelius um, lawsuit against CMS, they were always talking about an improvement standard to be able to
Mm-hmm.
continue in health, or even in outpatient you have to show improvement.
Improvement. Yeah.
But there's no more improvements. There has never been an improvement standard with Medicare, according to which I don't know why we always thought as therapists there has to be improvement to continue receiving services, but that's not the case any longer. Patients that probably would need maintenance care. When I say maintenance, for example, if you don't see them, they will decline significantly. For example, patients that have progressive neurologic disorders like Parkinson's disease
Parkinson's.
or stroke.
ALS.
If you don't do their exercises and all that, they will decline significantly. We can see them at a lesser number of frequency, for example, once a week, once every 2 weeks,
Mm-hmm.
things like that. You can continue seeing them. So basically, that's how home health and home health physical therapy entails.
Right, right. Because I remember for us, it's just going to be like the two criteria that you mentioned, which is the homebound status and a face-to-face encounter with your physician, and as long as the physician's gonna um, sign for the orders, and that's we're good to go.
Yeah. So I think it never changed.
Hmm.
Sometimes these criteria, they've always been there, but they just pinpoint on specific stuff that are related to our practice.
Right.
As, whereas,
Mhm. Uh, so for you, as a clinician and a business owner, how what would you say are the pros of working in home health?
okay, so this is the thing. There's a lot of clinicians that go to home health.
Mm-hmm.
Number one, because of the flexibility of schedule. So a
Mm-hmm.
lot of times, um, over the years, especially in California, most physical therapists are actually on a per visit type of setup with home health agencies, or they can be on a contract basis with the home health agencies, and there are very few salaried therapists.
Mm-hmm.
So recently, there have been a move towards more into salaried physical therapists compared to per visit after the PDGM, the patient-driven groupings model. But a lot of therapists want home health because of the flexibility in their schedule. If you have a growing family, you have little kids, you have to take them to school, pick them up, all that. You're caring for an elderly family member, so they move the schedule, the doctor's appointments or pharmacy pickup around the time of their home health patients. So that's number one. And number two, historically, home health uh, pays more, I would say, right? I
Mm-hmm.
don't know. It always uh, paid more compared to skilled nursing facilities or outpatient facilities. That's why a lot of therapists wanted to do part-time health. This is pre PDGM. So
Mm-hmm.
currently, I know a lot of therapists, PTOT, speech and assistants that lost their jobs with reduced hours for load, laid off, and all that stuff because of the PDGM. And we're only on the fourth month
Month.
of PDGM, and
Mm-hmm.
this pandemic happened. So it's like a
Right.
perfect storm
Right.
for and and lastly with California, for example, with the AB5, which prevents physical therapists to be independent contractors. That's
Contract.
really yeah, that's really a perfect storm for in California. It's only California anyway. So another good thing about home health practice is it molds you to practice in a holistic perspective. I know that when you were a physical therapist, or when you are in an outpatient setting or skilled nursing facility setting, you don't really ask about a lot of social determinants of psychosocial aspects of the patient. But
Right.
when you practice in home health, you go there, you interact with the patient family, you see the surroundings, you see the best and the worst of people, you see hoarders, you see racist patients and families, all that stuff. So that's the thing that you develop this type of holistic perspective in patient care that you don't really see in the other settings. So it makes you think that rehabilitation is not really focused on physical, but it's a lot of psychosocial aspects. So that's a big thing now with the American Physical Therapy Association. They always talk about the psychosocial determinants of health, because people who live in a rural area or don't have food to eat, don't have enough money, they tend to go to the hospital more frequently.
Mm-hmm.
And home health, you tend to see all of that, and you don't just go there as a home health PT. You become the jack of all trades. Sometimes you become a nurse because you have to change the dressing of the, although we do wound care, but a lot of home health PTs uh, uh, delegate that responsibility to nurses to do wound care. But you do other things. You can be home health aides, for example, a patient living alone, but you have to change the diapers and all that.
That
Things
is
like
true.
that. So
Mhm.
I'm sure you probably
Yeah, I have
it's
a funny story about that when you mentioned that, because there was a time that I went into a patient's house. He's wheelchair bound,
mm,
and but he can transfer by himself. And there was one time that he had an accident that he wasn't able to go fast enough to the toilet. So
uh-huh.
so what happened was, I got there and he said, "Well, could you help me with my situation in the bathroom?" I said, "What situation?" He said, "I didn't make it in the bathroom." I was like, so what happened? So yeah, just can you go to the my washer? There's a scraper there, and you can could you scrape off my my
I know what you
so off the floor. It's like, okay. It was like really, so what do I do? Do I have to like wait for his home health aid and relay that
mean.
information, or since I'm there I can help the patient? I was like, all right, since I want to build rapport with the patient, that was my second time seeing him. Okay, see, as I said, okay, I'll do this for him. Hopefully this will be the last time, but I'm gonna do this for him. So you're right, you turn to like a jack of all trades when you go into
Yeah,
home
you can
health.
be the home health.
Yeah.
And so, most often, you tend to become you become the nurse too. They ask you to help them call their doctors,
Mhm.
make appointments, and all that. So, initially when I started home health practice, I said, "Is this really part of my job responsibility?" Then
Right.
I realized, whatever it takes to help patients get rehabilitated, doesn't matter what it is,
Mm-hmm.
we have to do it, because when we are there representing the entire agency. So,
Mm-hmm.
like what I would say, any clinician, doesn't matter, a nurse, a PT, a home health aide, they can all be into one person. So I've done that several times, and a lot of my our therapists always have the stories like that, and we
Mm-hmm.
always laugh. It's part of our job. So
Right.
how about what is this? Uh, it teaches us teamwork and
Mm-hmm.
collaboration as well, because you're not just PT. You have to deal with the patient's family, doctors, the nurses, the OT, the speech, the home health aide, the social workers. So you become a member, an active member of the team.
Mm-hmm.
So collaborative, coordinated type of care. But what's really not, that I don't say if it's a con of home health. You know, uh, it has something to do with the payment structure. For example, are you salaried? Of course, if you're salaried, if there is a fluctuation of the number of visits, you will be paid the same amount. But
Mm-hmm.
if you're on a per visit rate, or a per diem rate, or a contractor, like this pandemic, we've seen probably a 40% decline in therapy visits, because a lot of the therapists, I mean, a lot of the patients would not want to be visited, or they're going to do telehealth. They said, let's just wait until the pandemic is over, then we can resume care. And for those that are per diem or per visit or contract, of course, they will have a decline in their payment.
Mm-hmm.
Number two, the PDGM, since January 1st, there have been a lot of layoffs, furloughs, change in employment status from full time to part time, decreased hours. So I don't know, as a as an industry, if home health is still a viable option at this time. Maybe I would say wait it out a little bit, because of all these perfect storm that has come to
Right.
home practice. Like I told you about EDGM, the pandemic, and also the AB5 in California, for example. So
Mm-hmm.
maybe wait it out a little bit. And number three, it's how do you say it? The agency's regard of the therapy team will make big impact in how you practice as well. Because prior to the PDGM, um, I know a lot of nursing agency, I know a lot of home health agencies, which are basically nursing agencies, have a high regard for the rehab team, because they drive the reimbursement.
Mm-hmm.
When you remember that uh, number of therapy visits part of the OASIS, and it drives the reimbursement. But now with the PDGM, because it doesn't drive the reimbursement any longer, a lot of nurse-owned or business-owned I mean, home health agencies have shifted their focus. They're not into therapy any longer. That's why there's a significant decrease in the number of therapy visits. So
Mm-hmm.
if agency is like that, of course you expect that they're probably going to get lesser visits. I even heard about multiple agencies in our area. Even a post-stroke patient, they're only allowing one visit a week,
Oh
and
wow.
not even sending any occupational therapy, which is very sad. For our agency, it's a different story.
Mm-hmm.
We are doing case management, so we check all the elements of the OASIS, the functional status of the
Mm-hmm.
patient, and we determine whatever the physical therapist requested is medically necessary.
Mm-hmm.
That's how we do it. So we even send PTs or OTs twice or three times a week, compared
Mm-hmm.
to the other agencies that even don't request for PT or OT any
Mm-hmm.
longer. So number four, we have to think about the financial stability of home health agency as well. Bigger agencies, of course, have more financial stability. But when you're working for a smaller home health agency, and if they don't have enough patients, then you're not going to be financially stable if you're just focusing on one job as a home health therapist. That's why at this point in time, I encourage a lot of my therapists to make sure that they have backup plans just in case the referral goes down, and so on and so forth. So
Right.
yeah, pretty much the pros and cons. Excuse me.
Yeah. But I think I don't know, but I think there's a discussion before that. I think home health is gonna pick up
Mhm.
because as much as possible, uh, I don't know if it's Medicare, but they want the patient to go straight home rather than stay in a skilled nursing facility. That's what I heard.
You
That.
know what? You're really right, because what they're saying is the future of healthcare is at home, and
Mm-hmm.
once until CMS recognizes the importance of home health in the overall care of
Mm-hmm.
patients, we can't get into that point yet. But
Mm-hmm.
that in a perspective point of view, we're looking forward to that because
Mm-hmm.
it's cheaper. I mean, a patient can stay in the acute hospital and spend how much would that be? $2,500 to $10,000 a day in an acute facility, and that's an entire 60-day episode for home health. Just imagine that. And
Mm-hmm.
the nursing facility gets paid almost $1,000 a day, right? Compared to an entire episode of home health, which can be on the average around 3,000 to $4,000 for a 60-day
Episode.
episode
Mm-hmm.
certification period. So it's so
Mm-hmm.
cheap. So if we look into that type of of thinking, definitely home health would be the best bet for a lot of patients, and also for on the CMS side of reducing costs.
Mm-hmm. Right. It would be more cost effective because sometimes the people sent in the skilled nursing facilities can be treated at home, as long as they have family to take care of them, or a caregiver that can be taught of some of the basic techniques.
Hmm.
Then it would be more effective for them to do their rehabilitation at home. Plus, they're in the comforts of their home. They're more relaxed rather
Hmm.
than being woken up every other time by the nurses, the occupational
They
therapist, the
cycle you
physical therapist. Right.
know.
So a lot of people might be best for them to be treated at home. So
Yeah,
I do.
like I was telling you that if CMS comes to a point and they recognize that, I'm very sure they'd want home health
Mm-hmm.
to act more active in the healthcare continuum more than
Mm-hmm.
skilled nursing facility or acute hospital, and it will be definitely very effective for them.
Mm-hmm.
So
Right. So could you describe to us what's a normal day of a uh, physical therapist in a home health setting look like?
okay, so if you're a full-time home health therapist, normally if you do Oasis,
Mm-hmm.
I would say maximum of 3 or 4 a week. in a day. But if you're just doing plain evaluations and treatments, you can see as many as six patients in a day.
Mhm.
What I usually do when for example I have an entire day of patients, I call a day before, and schedule all their appointments. What I do, I plot every single address of the patient strategically,
Mhm.
in a way that I don't have to go from one end of the town to the other end of the town. The good thing with where I practice here in the high desert area is if you are in a certain city or a few cities, it probably will not take 10, 15 minutes to drive from one patient to another. And if you're confined in one city, it probably would be less than 5 minutes compared to, like the Inland Empire where it takes you 30 minutes to an hour in between or something like because of traffic. And we don't experience that much unless it's a major thoroughfare in our area.
Mhm.
So that's how it is. We call ahead of time, schedule all the patients. Of course, expect some patients will say no,
Cancel, yeah.
or they will cancel. There are difficult patients that they say, okay, I'm available between 8 and 9 today, but as soon as you knock at their door, they're gonna say, oh, I'm not ready to do any physical therapy, things like that. So
Mhm.
expect those, but it's probably far and few in between. It's not a very, it's more of an exception more than the rule. So you have to prepare, of course, your everything that you need during the visits, your vital signs, your thermometer, and all that, and you bring the basic stuff for exercises. I have a balance foam, a board, a TheraBands, and all that. So whatever is in the plan of care, that's what I do. But I do a lot of um, functional stuff instead of exercises. The exercises I can teach them how to do it.
Mhm.
Um, them a video of I send them a home exercise program that they can do every day. So, but I don't focus much on that. Maybe the first 2 or 3 visits, I do exercise so that they can get into this groove of doing the exercise. But the bulk of my visit is functional. I'm getting in and out of the tub, getting in and out of the uh, the car,
Mhm.
work on stairs, safety. Rearranging the house, open up the hallways and all that if needed, if the patients will allow you. So
Mhm.
basically, at home for home health physical therapy practice, it's a lot of home safety, functional training, making sure that they're safe at home, and once they're ready, they can get in and out of their car. Somebody can take them to a physical therapy place, for example. You can send them, refer them to the outpatient
Yeah.
therapy place.
Right. So I agree that the main goal for home health physical therapy is their safety at home primarily and help them not go back to the hospital.
Right.
Prevent them from going back to the hospital. Nice. So we talked about earlier, for like this is for therapists who are about to go to home health and what things they need to know. So we talked about earlier if you're going to be a salaried physical therapist or per visit physical therapist, and you also lightly touched on the area of coverage for physical therapists. So some physical therapists would cover a lot of like counties, right? And some would have really have a concentration on certain towns. So that's one thing a therapist should know. So other than that, are there other things that a therapist should probably ask or inquire the home health agency or company when they're about to start their
Okay.
practice?
Okay. pretty much before getting into home health practice or home health business, for example, we have to really know what's the reason. I mean,
Mm-hmm.
what's our motivation? Is
Mm-hmm.
it flexibility of schedule? Is
Mm-hmm.
it the pay? Is it the money? Is it
Mm-hmm.
freedom? So
Right.
I mean, I say freedom because when I say you do home health, you go, drive from one place to
To
another,
another.
and for me, I love that because I felt free when I
Mm-hmm.
was doing home health. So you have to have your own personal reason why you're shifting to home health. So if the case is flexibility, then home health is definitely your choice.
Mm-hmm.
I don't know with the pay currently, but like I told you, anecdotally or historically, it's always been a higher pay for home health therapists,
Right.
and freedom, definitely more freedom for me. As a home health therapist, you cannot just go there, and you need to be trained
Mm-hmm.
because there are a lot of regulations. So you have to know home health regulations and guidelines, as
Right.
simple as homebound status.
Yeah.
Not if it's Medicare A, which is paying for the home health of the patient, we have to be bound by that criterion, which is homebound status. Be homebound. If they're not homebound, then they're not appropriate for home health. So you should know these regulations and guidelines. So
Mm-hmm.
the federal guidelines coming from the Center for Medicare and Medicaid Services, there can be state specific guidelines, of course, from your like for example for us from the California Department of Health, it can be guidelines from the accrediting agency. In the home health setting now, there are three um, accrediting agencies: the Joint Commission, uh, CHAPS, and ACHC. And you have to, be familiar with their guidelines. But most of the time, prior to doing home health, at least your home health agency that you're going to work with or you're going to work for should at least train you on their guidelines. And lastly, for agency specific policies, because
Mm-hmm.
always remember, we always follow the strictest.
Mm-hmm.
So if they're federal, state, or accrediting agency guidelines, but if your guideline in your own home health agency is stricter in your written policies and procedures, we should follow
The stricter
those.
guideline.
More
Mm-hmm.
strict, whatever's the strictest, we should follow. So aside from that, if if you're a therapist, you should get used to being a member of a multidisciplinary team, so you don't go in a patient's home alone. When I say alone, it means that there are other disciplines that you need to coordinate care with: the nurse, the social worker, the OT, speech, and so on and so forth. So you need to get used to being part of a multidisciplinary team. Number four, you need to be open-minded. Like what we talked about a while ago, you see the best and the worst of people, right? When you go to home health. But it's amazing. The home health setting is a different setting because um, patients and their families are allowing a stranger to go to their home, right?
Mm-hmm.
So, and that's a leap of faith for a lot of patients. Some patients would refuse us to go there because they're not comfortable having another person or a stranger to go there. So that's why it's very important for us home health therapists to be open-minded, in a sense that whatever we see in that patient's home, or however the patients or the family members react to us, we should be able to adjust or adapt to that right away. Correct? Because
Right.
when you go to a patient's home and you see the best and the worst, you can see the best, nicest houses, but you
House.
can see the worst. Cluttered hoarders
Mm-hmm.
and all that.
Mm-hmm.
Nothing cat fur, full of cat poop.
That's true.
Um, don't have anywhere to sit. Things like that. You have to be open minded that
Mm,
it's not going to be ideal. Not every single patient's home is like your home.
mm-hmm,
So, because always remember, a lot of our patients in home health, I would say majority probably are seniors, 65 plus, and most of
mm,
these people have enough money to actually really take care of themselves and their homes. They don't
mm,
have anyone that can go there and actually clean
mm,
with frailty, so disability, and all of that. They cannot clean their home and all that, and they have the tendency to be to have a lot of animals with
mm.
them
Right.
because they're lonely.
Right.
So the only one of the things that they can do is have somebody to talk to or somebody to take care of, which are animals. So we can see all of that. So, and lastly, you have to be you have to accept the responsibility that you are not there as a therapist only. You can be jack of all trades, which was we talked about a while ago. We can be a CNA or a home health aide. We can be a social worker. We can be a nurse, and so on and so forth. So
Right.
yeah, those are things that they need to look into. And if they're ready, then home health is actually, I would say, um, the best setting to rehabilitate patients. It's very I cannot fathom the word. It's a very rewarding experience if you see these patients from completely bed bound or something like that when you see or they are maximal assist when you see them
Mm,
initially and
mm,
eventually being able to drive their car, things like that.
mm.
So in any setting anyway, but in the home health setting, it's pretty much you know you're already there right before you progress them to the outpatient. They're pretty much almost independent and safe at home when you discharge.
Right. So for me, what I like about working in home health is, as a clinician, you have the independence of providing the intervention that they really needed at home. So
Mhm.
you're not really stuck with, like what you said, to the exercises. You
Okay, yeah.
can, yeah, you can go more functional. You can go up and down the stairs. What do you do around the house? What would make you safe if I leave you? And those
Mhm.
kinds of things, as well as you can concentrate more on patient education that you can't
Mhm.
really do in a skilled nursing facility, where you can just like imagine what their house is like. But in home health,
Mhm.
you're already in their house. What can I educate you for to make you more safe here? So
Mhm.
yeah, that's good. So you mentioned being holistic and collaborative, and open-minded, being yeah, a jack of all trades. So for
Yeah.
you, what was the what do you call this, greatest lesson that you learned from your home health experience?
Pretty much the I would say the greatest lesson. I would say in a perspective of a owner of a home health agency, I would say is the most important lesson is it taught me to really advocate for our patients and our community. So I'm not just advocating in a perspective of a physical therapist, but it's more on helping the healthcare delivery system in our community to work more efficiently and be part of the solution more than part of the problem. That's why when for me, I usually attend post-acute collaborative meetings with skilled nursing facility administrators and home health agency owners and all that. When we talk about how we work together as a as part of the healthcare delivery system, we realize that when we become not competitors, but more on we collaborate with each other, help each other. I think it helps prevent patients from being rehospitalized. And I would say overall that's the most rewarding part of being a business owner. And also it also taught me and my wife what you call resilience.
Mm.
When you're a business owner, there will be ups and downs, peaks and troughs in your business. There will be a point where it's do my wife and I talk about, do we want to continue with this business or not. I'll share you. I usually don't share this private information, but for the sake of those therapists who, or even clinicians who want to delve into having their own home health agency or hospice agency, that there's a lot of trade-offs with owning a business. Trade off your time for your family, trade off money, um, a lot of things. And during our first 2 years after we acquired Imperial Home Health, it came to a point that it literally exhausted all our financial resources. So it came to a point where all our bank accounts are zero. We're done to almost max out all our credit cards. And it came to a point where we have to dig into coins from our little our water bottle where we put all our coins in there just to use it for offering in church.
Oh.
It came to that point, and we it was an aha moment for us, because we told ourselves, is it still worth it to move forward
Mm.
after all of these happened, because we can just let go and get salary jobs. I even thought of I can work at Kaiser and all that. So, but we persisted. We said we're already in the middle. I know it's part of every business. There's like a struggle, and we said we hit the wall, and we said, should we continue? And we continued. We were resilient, so we moved past that point, and we became, I would say, successful in a way. So, I think those are the lessons that we learned from owning a home health business.
Oh, so I guess you already answered one of my questions. What do you think physical therapists need to possess in order to succeed? You mentioned being resilient.
Hmm.
Do you have something to add to that? So aside from resilience.
You know, how about let's just focus on what what does it take for us to create our own home health business. So
Mhm.
let's because we're going to talk about that anyways. So first of all, you need to know what type of business you want to get into. Is it home health contracting? Is it home Medicare B outpatient at patient's home? Or is it owning a certified Medicare certified home health agency like us?
Mhm.
And you need to know what your goals are. What scale do you want to remain small, medium, or large? But normally, when you start small, you eventually have bigger dreams,
Plans,
right?
yeah.
So
Mhm.
there are a lot of things that you need to take into consideration. What number one? What's your motivation? Is it money? There's a lot of clinicians. Number one motivation is money, and I cannot I not disagree with them having money as their main motivation. It's okay. It's okay to have that. Is it advancement? Is it ambition? So it really depends. Number two, are you business oriented? Not everyone is, are born to be business owners. I believe some people can learn to be business owners, but there are people who are really born to be business owners. If you know that if you're that type of person, that always remember that to be a business owner, you're not only thinking about yourself, you're
Mm.
thinking about the people that work for you,
For you. Mm-hmm.
correct? So you have to have adequate knowledge on dealing with people. Uh, Sorry, my daughter is here again. So where were we? Not all people are business oriented. So you have to learn some basics on business, how to manage money, how to manage people, how to
Mm.
manage referrals,
Right.
how to be uh, more people oriented, which is one thing that we're still working on. You know, and you also have to have the money,
Mm.
correct?
Yeah.
So if you want to own a home health contracting, probably will not require you to have the capital, but it will require your human capital, which is your
Mm.
effort. Yeah,
Mm-hmm.
and also the possibility that these agencies that you will be contracted with will not pay you. You have to have that in mind, because even though you have contracts, there's always a chance that they will pay you. But if you want to have like a um, Medicare home health agency, you have to have enough money. You have to know if you want to do a startup home health agency, or are you just going to acquire an existing home health agency. For us, we never did start. We all did acquire an existing home health agency. We felt that time is of essence and time is money. So if we're gonna do a startup, it's gonna take us a long period of time to get Medicare certified. Probably will take us 2 to 3 years to even get our Medicare. I mean certification number. So
Mm-hmm.
so at least there were multiple therapists that actually messaged me and spoke to me about what how does it take how much money do I need to start a home health agency. I would say at least 300,000
Wow. It's like
to
a
start
house.
a yeah, to start a Medicare home health agency. It doesn't matter if you acquire it or if you do a startup, but that's around the rough ballpark number. And the thing there is, if you do, for example, a startup, you have to have your own office, you have to have your own administrator, so you have to pay them until the time that Medicare gives you your Medicare number. Once you can, that's the only time you can start billing, and that will be probably on the third or fourth year. So, but if
Wow.
you when you buy a home health agency that has already the Medicare number with billing ability, for example, you pay for it for 300,000, 400,000. You still have to have enough money for at least 2 years that you'll be able to, because you cannot uh, the ability to build networks of referrals takes time. It
Mm-hmm.
doesn't like you just go to the hospital and they will send you patients. No, that doesn't it doesn't work that way. You have to always be present, go there on a weekly basis. You have marketers, and they have to see you consistently before they even look at your brochure and all that. And it takes some time. For us, it took us probably 2 years to get established in our agency. So that's number three, money. Number four, guts, guts and guts. So you have to want it. I mean,
Mm.
I have told many therapists that ask me, what does it take? I said, you have to want it. You have to have the guts. You have, if you're 50% only for it, don't do it, because it will take a lot of your time. It will take a lot of your money, and you know to be able to get to that, do the leap of faith, you have to have the guts. Number five, you have to have the heart for advocacies. I mean, you have to advocate for your patients, you have to advocate for your community. I think that's a very important aspect, because if you're just there for the money, I think money will come and flow afterwards, but the most important thing is to take care of your patients, at the same time taking care of your community. There's a lot of trade-offs, like I was telling you about time. If you have a growing family, I don't recommend it to, because it will take a lot of your time away from your family.
Mhm.
Having a business, dealing with the federal government, the state, the accrediting agencies, and all that, and dealing with so many people, you have to trade off the family time. You have to trade off, the precious times for your children. For us, we when we started our home health agency, we had a young kid, and now we have another young little girl. So
Oh,
we're already there. That's why we just persisted. We just, we said we'll just continue. Next, when you reach to a point where you hit the wall, like I was telling you a while ago, it's very important, to muster all your strength. And we've already um, gone a long way, already halfway, or why would you stop in the middle? So just persist, just be resilient. Number is it number seven? You also have to know the market or the competition in your area. Not all areas are conducive for home health. If you go to Texas, for example, Houston has more home health agencies. I think four home health agencies per Medicare recipient in Houston. So,
really?
or if you go to like Miami or Ohio and all that, they have a high density of agencies in their area. There are more agencies than Medicare patients. So
Wow.
the good, yeah, that's good to know. The hot spots in for the OIG, for example, they will show you where the agencies are concentrated in the United States. The good thing for us when we moved here to Victorville is, it's multiple cities within short distances from each other. It's not traffic. You get traffic once in a while, but not a lot. So, and there are only very few home health agencies here. Most home health agencies are those that come from down the hill, down your area,
Mhm.
Rancho, Ontario, Vina, and they come up here. So there are only very few. And it was a good thing for us. And we were there at the right time as well, because when we started our agency, the VNA of Inland Empire, they had a big office here. They were VNA here. But during that time when we started, they closed.
Oh,
We were there at the perfect time.
timing.
So I think I would say ultimately it's divine grace. It's you know, it's there's always divine intervention in everything that we do. So
Mm.
if you um, people listening here, I'm not trying to be religious, but if there's a higher being that you believe in, I'm very sure it will really help throughout your journey. So
Right. Yeah,
that's it.
that's a nice tip to starting your business. So we're close to our end. Um, my last question would be like, what are the three ingredients that are essential in your life right now that you carry with you in your everyday life, in your work, in how you interact with others? There's three ingredients. Uh, it may be an event, person, or whatever. that you are always carrying with you?
I think first and foremost, I'm a very religious person, so I believe that there's always God's plan for each and every one of us, and we're just instruments of God. If I feel like we're just extenders of God's hands to help people, especially in their rehabilitation from the hospital to home. So I think that's number one. And everything I do, not just with home health, number one, God is always number one. Number two, another one of the things that I learned from multiple people is the importance of uh, networking with people. I think if you're familiar with Mike Chua from AFAPT,
Mm-hmm,
he is somebody who has the most number of networks. I would
right.
say I'm author in the United States. I
Mm-hmm,
I would say that actually that's the greatest asset. I mean, it's more than money. I mean, having a lot of people to
mm-hmm,
network with, you can pull every time you need help is, I think that one of the greatest wealth.
mm-hmm,
And number three, I think I would say family is uh, one of the most important thing. You're doing what you're doing because of your family. I think it caps everything, that it provides you the inspiration and motivation to go on. It doesn't matter if it's difficult time or it is the happy time. So that's it. I think those are the three things that I can share with your listeners or viewers.
right. So there. So faith, networking, and family. Yeah,
Yeah.
yeah. I agree with you with the networking part because yeah, it's nice to have people to really contact if you have any questions that are like your resource persons. If you have
Mm.
any issues with some things. So as an ending, what would you want our audience to take away from this episode?
Okay, pretty much if you want to, it doesn't matter if it's home health, outpatient, or whatever type of practice. If you really want to do something, you have to put all your heart and soul into it. You have to want it. You have to do it. Okay, no ifs and buts. It doesn't matter. You hit the wall. It's difficult time. Just persist. I mean, if you really want something, go for it. I think that's the last thing I want to tell everyone who's listening or
Yeah,
viewing.
that's powerful advice, right? So again, thank you, Ellie, for sharing your time with us and your experience and your wisdom in home health.
Okay, thank you very much, Johan. And, we'll see you maybe next year or one of these days. Oh, you just
Next CSM. Oh,
hour
here.
away.
We're just
But over, I'll just message you. We're in West Covina.
right. Let's share some Jollibee here.
Or Mac or something
Uh-huh.
like that.
All
Or
right.
Gold Delight.
All right. Thank you.